Hello everyone, I'm Dr. Akshata Prakash and today we'll be learning about corneal ulcers. Corneal ulcer, they're also called keratitis. Okay? Keratitis means corneal ulcer. Kera means cornea and itis means inflammation. So any inflammation in the cornea is called keratitis. If it has to be an ulcer, there has to be two components. One is your epithelial defect. Along with that means it has to be a breach in your epithelium. Along with this, there has to be necrosis. Necrosis of your underlying tissue. The underlying tissue here is your stroma. So it has to be a breach in the epithelium, that is your epithelial defect. Along with that, necrosis of your underlying stroma. That has to be a corneal definition of a corneal ulcer. These two components, if they are there, that is when you coin the term corneal ulcer. There has been a broad classification for corneal ulcer. One is your infective, the other one is your non-infective. From your MCQ point of view, we have infective, which is being asked more commonly than your non-infective. Infective, it is according to the etiology that has been causing your the corneal ulcer. In this, we have bacteria, fungal, viral, and protozoal. First, we will deal about your bacterial corneal ulcer. Any corneal ulcer, they will complain of redness, pain, photophobia, watering, discharge, and some whitish material on the cornea. These are the symptoms which is common to all your corneal ulcers. How do you differentiate a bacterial corneal ulcer from a fungal corneal ulcer? There has to be certain differences. In your bacterial corneal ulcer, if this is your cornea, there is an ulcer here. It is going to appear wet looking. The surface will be wet looking. That is, there are more exudates. There is more inflammatory exudates. That is why it is wet. Whereas in your fungal, it will be dry. How do we say this? How do we differentiate these two? It comes with experience. Once you start seeing corneal ulcers, you know which is wet looking, which is dry looking. For now, we'll just remember it as wet looking ulcer. It can also have hypopion. It is not a must, but it can have hypopion. So this hypopion here is sterile. This has been asked n number of times in your MCQs. What do we understand by sterile hypopion? What is hypopion? Hypopion is nothing but pus in anterior chamber. Okay. Pus in your anterior chamber is sterile. What do we understand? That means the organisms are not penetrating the cornea. They are not going inside the eye. If we take a sample and send it for laboratory culture, it is going to be negative. No growth in your bacterial corneal ulcer. In your bacterial corneal ulcer, this is sterile. Remember, only in your bacterial corneal ulcer, because in fungal, it is not sterile. Coming to the organisms that are most commonly involved with your bacterial corneal ulcer, you have Streptococcus pneumoniae, you have Staph epidermidis, Staph aureus. There are many more. But we have to remember 4 organisms which are known to penetrate intact cornea. This is your cornea cut section. This is your epithelial side. This is your endothelium. So most of your corneal ulcer, if it is here, even if your bacteria is in the conjunctiva, it doesn't usually cause a corneal ulcer. They don't. There has to be some epithelial defect. There has to be a breach where the organisms can gain entry. But there are few organisms that are known to cause, they're known to cross the cornea, intact corneal epithelium. It is Neisseria gonorrhoeae, Neisseria meningitis, Listeria monocytogenes, Cornybacterium diphtheria. They can give 4 options and they can say which one does not penetrate the intact corneal epithelium. You have to look out for these 4 options. Whichever is there, you have to mark, which will rule out the others. if they are staph or something. Another MCQ that they can ask here is, what is the most common, what is the organism, either a bacterial corneal ulcer, which can mimic fungal corneal ulcer? So in this case, it would be nocardia. The answer is very simple and straightforward. It is nocardia. So nocardia is one bacteria. It is atypical mycobacteria, which can mimic a fungal corneal ulcer. It behaves like a fungal corneal ulcer, but in fact, it is a bacterial corneal ulcer. Once we have dealt with the clinical features and the organisms, the next thing that we have to deal with is how do we culture them. So we can do gram staining, and then we can have blood in agar, blood agar, chocolate agar, depending on the organism. We can grow these organisms which are picked up in your gram stain. So to pick up a sample, if this is your cornea and if this is an ulcer, we have to do scraping. Scraping can be done with needle or blade, whichever is convenient. It has to be done at the base and also the margin. So you have to include the base and the margin in your scraping material. Then we have to stain, we have to mount it on the glass slide and then send it to microbiology for gram staining and culture. All right, this is with your bacterial. And then the treatment options come. So the treatment will be mostly your antibiotics in your bacterial corneal ulcer. Most common used antibiotic topically is moxifloxacin in the form of eye drops. But in case of your corneal ulcers, we give them fortified antibiotics. What do we understand by fortified antibiotics? These antibiotics are not available in the form of eye drops. They are your IV antibiotics. They are fortified to a concentration mixed with your carboxymethyl cellulose and then given in the form of eye drops so that their concentration increases, because in IV, the intraocular or in the penetration, it is less. So we have to give them loaded with so much of antibiotic concentration that the bacteria will eventually die in a corneal ulcer. So in this, the antibiotic that are fortified are more commonly cefazolin, 5%, vancomycin, 5%, and ceftazidime. There are many more to it, depending on what positive it is. Mostly cefazolin is very good because it's broad spectrum. Along with your antibiotics, we have to give them cycloplegics in the form of atropine eye ointment. Why do we need cycloplegics? It is to reduce the pain caused by ciliary spasm because of your iritis. This can cause iritis, and that is going to cause ciliary spasm, that is going to cause severe pain. So you can reduce some amount of pain by giving cycloplegics and supportive treatment like oral painkillers. And with vitamin C, B, A for faster wound healing. Okay. Another specific bacterial corneal ulcer that we deal with is something that we have all known is your ulcus serpens. Why do we call it serpens? Because it is in the form, it spreads in the form of a snake. That is why they call it ulcus serpens, or they call it hypopion corneal ulcer. So case here stands for cornea. It's called hypopion corneal ulcer. What do we understand by hypopion corneal ulcer? Why it has to be called hypopion corneal ulcer? Because your bacterial corneal ulcer may or may not have hypopion, but this corneal ulcer, this bacteria will definitely have hypopion. And if left untreated, in the second day or third day, it is going to be so fulminant because it spreads in the snake-like pattern. It's going to spread so fast that you would not believe it is a bacterial corneal ulcer that you have seen in a day before and doesn't progress to this stage because of a lag in treatment. So the organism responsible for this is your Streptococcus pneumoniae. Where do we get this organism in eye? How do we get this organism? It is because if this is your nose, this is your lacrimal sac. Okay. So this lacrimal sac, if it is infected, that is your chronic dacryocystitis. This will have Streptococcus pneumoniae as your causative organism. And this is the reason why this patient has developed ulcus serpens or hypopion corneal ulcer. Okay, we are clear with the bacterial corneal ulcers. So now we'll move on to fungal corneal ulcer. Here, the fungal corneal ulcer is more common in your tropical countries. So in India, if we have to say which is common, it is your fungal corneal ulcer because India is a tropical country. Fungus usually grows in dry, moist environments. So tropical countries are your favorite for your fungals, anywhere, any fungal lesion. And in ulcers, corneal ulcers, it has to be fungal corneal ulcer if the patient is coming from a tropical country. Whereas in your Western countries, it is your bacterial corneal ulcer that is more common. What is the most common organism? They have asked this before also in your MCQs. What is the most common organism in your fungal corneal ulcer? If they ask fungal corneal ulcer, remember I'm stressing onto the point as fungal corneal ulcer. If they ask fungal corneal ulcer, most common organism, it has to be Aspergillus. There is no other organism that is more common than your Aspergillus. Various strains, Aspergillus fumigatus, whatever it is, but it has to be Aspergillus. But if they ask the most common fungal infection of eyelid, so now you please understand they are trying to confuse you by saying it is eye. But still, eyelid is a part of your skin. It is covered by skin. In skin, the most common fungal organism that is responsible is your candida. More common for your infections is candida. In eyelid, it has to be candida. It cannot be aspergillus. But if they ask ulcer, it is aspergillus. Okay, we are all clear about this. A little more into this, they can ask about the microbiology part. Very little, but they can still ask. They can ask, instead of aspergillus, they can say it is a filamentous fungi. As it is septate and branching. Instead of saying the most common organism and giving the option as aspergillus, because we all know it as aspergillus, they can say it is filamentous fungi with septate and branching hyphae. Branching hyphae. So a little microbiology added to your ophthalmology, they can still confuse you. You should be knowing about this. That is all about your fungal corneal ulcer organisms. Coming to the clinical picture, here we all know the signs and symptoms are very less compared to the size of the ulcer. In bacteria, it is proportionate to the size. The size is big, the symptoms are more. In fungal corneal ulcer, the size is very big. The size of the corneal ulcer is very big. This patient is quite comfortable. He's not much pain. He's not saying he's having so much of discomfort. Mild discomfort. But when you look into the ulcer, it is quite big. He should have had more. That gives you a clue of your fungal corneal ulcer. Another clue in your history that you can pick up, or rather, most of your MCQs begin with history of trauma with animal tail or wooden stick. We have seen this in most of your MCQs that they keep saying history of trauma with vegetative material. So vegetative material is in history, it is your fungal corneal ulcer. Without much doubt, you should be able to click onto the fungal corneal ulcer as your right option. All right. Along with this, there are certain typical features of your fungal corneal ulcer. They say it is dry looking. They can give into the description of dry looking ulcer that the surface is dry. In bacteria, it is wet. They can have feathery margins. So if this is your ulcer, fungal corneal ulcer, they can have these feathery margins. And this is the main ulcer, okay? There are ulcers here also. Remember, this is separate from your main ulcer, but still they are small ulcers. So these are called satellite lesions. It is the most specific for your fungal corneal ulcer. The most specific sign for your fungal corneal ulcer. They have asked, there are different things that you can have: dry looking, feathery margin, satellite lesion, and you can also have immune ring of Wesley. Wesley's immune ring. It is just an immune reaction to your fungal antigens. So the cornea can have, and you can have a Wesley's ring. But it is not specific for your fungal corneal ulcer. The most specific is just satellite lesion. Then we can come into hypopyon. What we learned in the bacterial corneal ulcer that the hypopyon is sterile. Here it is not sterile. Hypopyon is, again, to remember, it is pus in your anterior chamber. This is not sterile, okay? That means if you culture and send it to laboratory, you will find aspergillus. Most common is aspergillus. That is why I'm stressing on to aspergillus, okay? This gives us a clue for the fungal corneal ulcer. And coming to the treatment options, before that, the investigations, we have to do KOH mount, okay? There with the grams stain, okay? Here we are doing KOH mount. And for culture, we can do it on Sebaros, dextrose, agar. And we are going to get whatever it is, whatever organism. Most common is, again, aspergillus. The treatment for these will be your antifungals. We have a list for the classification, this pharmacology for antifungals. The most common here used is your broad spectrum natamycin 5% eye drops. Okay, this is most commonly used because it is broad spectrum. Others are amphotericin B, itraconazole, ketoconazole, and so on. Okay, if it is aspergillus, use natamycin. If it is candida, use amphotericin B. Amphotericin B is again in your IV form. It has to be prepared in the eye drop form and then given. Your itraconazole, ketoconazole are available, and also voriconazole. This is about your fungal corneal ulcer. Next, we are going to talk about viral corneal ulcers. The most common organism here is your herpes simplex virus. Okay. There can be others also, molluscum and everything, but they do not cause corneal ulcer. The corneal ulcer, if you say viral, it is herpetic corneal ulcer. The other term that is synonymous with your herpes simplex virus is dendritic ulcer. Why do we call it as a dendritic ulcer? What do we understand by dendrite? Means it is long, it is branching, and it has terminal bulbs. Okay. They have terminal bulbs. So if this is your cornea, you have your dendritic ulcer here. That they are long. Again, I'm going to repeat. They are long branches. They have terminal bulbs. What are these terminal bulbs? Terminal bulbs are nothing but your virus-laden dead epithelial cells. So they have virus inside it, but they are dead epithelial cells, corneal epithelial cells. They take up rose Bengal stain. Okay. Whereas these dendritic ulcers, these branches are going to be green. That is, it's going to take up fluorescein stain. And your rose Bengal, as you say rose, it is red. So they take up rose Bengal, only your terminal bulbs. Why am I stressing so much on your dendritic ulcer is because it is a true dendritic ulcer. What is the other thing? That is your false dendritic ulcer. It is also called as your pseudodendrites. Okay. What are the causes for pseudodendrites is your question. Herpes zoster ophthalmicus, trivial trauma like your paper cut or something can also cause pseudodendrites. One more is your acanthamoeba. Okay. So the causes for your pseudodendrites are these. How do we differentiate pseudodendrites from true dendrites? There won't be any terminal bulbs in your pseudodendrites. Okay. And they are in the periphery. They are short branching and no terminal bulbs. So this terminal bulbs are not there. The long is not there, only short. That is your pseudodendrite. And they are in the periphery. That is why the diagram that says this is in the center. Center of your cornea is your true dendrites. Periphery, it is your pseudodendrites. Clear? We are very clear with this. We have to next move on to your dendritic ulcer. What are the stages for your dendritic ulcer? First, they form superficial punctate keratitis. They are just like dots. Then they progress to dendritic ulcer, which we just described. Then these dendrites may actually coalesce like this. Okay. Then this whole of it can form geographical ulcer. So this whole thing will coalesce. The branching and all will coalesce and they can form geographical ulcer. Okay. The next stage is necrosis, your stromal necrosis. Okay, when the virus actually penetrates into the stroma and it causes necrosis, it is an intense reaction, the whole thing gets sloughed off, there is thinning, there might lead to perforation also. That is your stromal necrosis. This is your virus keratitis. There is another reactionary keratitis by a virus, which we call it as disciform keratitis. It is called disciform keratitis. Okay, what do we understand by disciform keratitis? Disc shape, that is why it is in the form of disc. This is in the center, disc shape. This will appear cloudy. The center of the cornea appears cloudy. Why does this happen? Because there is endothelial dysfunction. Okay, at that particular area. So it fails to pump out the aqueous from the stroma. That's why the aqueous enters into the stroma and it hydrates. So that is why it is appearing cloudy. But this nowhere the virus is present. Virus is typically absent because it is just your immune reaction. Virus is not present. Another thing that can add on to this stromal necrosis after this disciform is your Metaherpetic keratitis. What do we understand by metaherpetic keratitis? In this, the cornea, there is a persistent epithelial defect and decreased corneal sensations. K is the term used for cornea everywhere. Do not get confused. You have decreased corneal sensation and the epithelial defect just doesn't heal. The new epithelial cells doesn't migrate and it doesn't heal. That is when we term the coin metaherpetic keratitis. It is very specific for your virus keratitis. Okay. After this, we will move on to protozoal, that is your acanthamoeba, that is your last corneal ulcer. Protozoal corneal ulcer. The only name that comes to your mind should be acanthamoeba. Okay. There is a typical history in this, that is history of contact lens use. Okay. And the patient has gone for swimming in freshwater pond. Most of your MCQs, if they begin with this and they say there is corneal ulcer, it is implicated that it has to be acanthamoeba. Okay. The two common features, distinguishing features here, there are pseudodendrites here also. We have already learned Wesley's immune ring. That is also there in fungal corneal ulcer. It is also there in acanthamoeba. What is so different about this is intense pain. The pain is too much. Fungal corneal ulcer, no pain. Patient is quite comfortable. Mild discomfort may be very big corneal ulcer. Here, the corneal ulcer has just started, but the patient is cripping of pain. He just doesn't stop complaining about pain. That is because of your radial perineuritis. That means the acanthamoeba actually invades along the corneal nerves, and these corneal nerves are present in large number. It is densely innervated in the cornea, and they invade along these corneal nerves. That is when the pains begin. That is when you have to suspect, strong suspicion of acanthamoeba should be there. Otherwise, it mimics your fungal corneal ulcer. So there are two organisms that are going to mimic your fungal corneal ulcer. One is your protozoal, that is your acanthamoeba. One is your bacteria, that is your nocardia. These have been asked in your MCQs previously, so you better know about them. Then coming to the treatment options here, two drugs, PHMB, polyhexamethylene bigonide and chlorhexidine. These are the drug of choice for your acanthamoeba corneal ulcer. Along with this, they can also give neomycin. And your neomycin is your antibiotic. And your antifungals like itraconazole, ketoconazole, and so on. Okay. So this completes the in general the infective causes for your corneal ulcers. We've learned what the most common, where they can ask, what is the presentation and how different is it and which can mimic what corneal ulcer. Also the treatment options available. So let's see the MCQs. Here they have asked, it's the NEET PG 2022 question. Here they have asked, what is the dye and filter used to diagnose corneal ulcer? Please remember the dye here used always it is fluorescein dye. Okay. It has to be fluorescein dye and the filter has to be cobalt blue. You would remember seeing corneal ulcer, which appears little green. So you say it is green filter. It is not. It is not a green filter. It is the cobalt blue filter. The corneal ulcer appears fluorescent green in color, but it is not a green filter. Most of you who have attempted this have written this. This is not your right answer. This is your correct choice. This fluorescent dye, cobalt blue filter. This has to be the correct answer. Okay. So we move on to the next question, or rather, we'll just see the picture first. So this is your corneal ulcer. Right, here is your corneal ulcer. And this is under cobalt blue filter. Both of them have been stained with fluorescent dye. It is better appreciated here, the second picture where cobalt blue filter is used. So this filter, what they have used here is blue. You can see the blue light. That is your cobalt blue filter. Here, there is no filter used. It still appears green, but still, if you want to appreciate, delineate it better, it is in this picture that you can delineate it. It appears green, but the filter is always blue. And the dye is sodium fluorescent. Coming to your next question. This question was asked in INI-CT 2022. So see this question properly. A patient with animal tail trauma. So here you see a animal tail trauma. It is again a vegetative matter trivial trauma. The patient presented with the following clinical anterior segment photograph. You can see this arrow that has been pointed. They're asking you, what is this feature called? So you can see the pus in the anterior chamber here settling. This should be your hypopion. So the correct answer for this question is hypopion. Hyphema means blood in the anterior chamber. That is not the correct answer. Aqueous flare, it's usually seen in slit lamp, not in this clinical picture seen, and seen in uveitis more. Glaucoma flexion, seen in your other condition, it is not this. Okay, it's a cataractus condition, it is not this. Then we move on to the next question. It was asked in your NEET PG 2020. What is the characteristic feature of a fungal corneal ulcer? The options are reverse hypopion, dendritic ulcer, ring abscess, or satellite lesion. I have repeated this n number of times. If they ask characteristic fungal corneal ulcer, it has to be satellite lesion. Without any doubt, it has to be satellite lesion. Where do we see reverse hypopion? What do you understand by reverse hypopion? It is very simple. This is your cornea. Hypopion is usually seen in the inferior part. Because of the gravity, it settles down. But reverse hypopion, you see it here. So what is this condition where you see reverse hypopion? If this is filled with silicon oil. So we all know oil and water has to float above the oil, right? It cannot go down. So oil is dense, so it comes down and the water will float. The same thing here. Gravity doesn't work. In silicon oil filled eyes, that is your post-vitrectomized eyes, you have silicon oil floating up and your aqueous or the oil below, right? But this is not your correct answer. Dendritic ulcer is almost synonymous with viral keratitis. Until and unless mentioned, it is assumed it is viral keratitis. You do not see dendritic ulcer or a fungal corneal ulcer. Ring abscess, we see Wesley's immune ring. It is not an abscess. It is a sterile ring. That's the sterile immune ring. So the correct answer is your satellite lesion. Okay. We move on to the next question, which was asked in your INI-CT 2021. A patient presented with a swollen left eye, history of vegetative matter. So now they have actually mentioned vegetative matter trauma. So here we know it is fungal. We are dealing with a fungal corneal ulcer. A few days back, there is a corneal ulcer. They have mentioned about corneal ulcer. Now we know the causative organism. It is fungus. And that ulcer is associated with hypopion. The pathological slide shows staining with methenamine. Which of the following is the most probable class of organism involved? Here, indirectly, they have given you a lot of clues towards fungal corneal ulcer. Your correct option is fungal corneal keratitis. But also remember methenamine silver stain. This is used in your histopathological slides. Take the fungus. Okay, so we are now clear with these things. We'll go on to the next question, which was asked in NEET PG 2020. They have given you a clinical scenario. A 26-year-old male presented with redness and watering from right eye. He is diagnosed to have herpes simplex keratitis. They have given off the diagnosis as herpes simplex keratitis. Which of the following is characteristic feature of this type of keratitis? So now they have asked which is the characteristic feature of herpes simplex keratitis. Your options are satellite lesion, dendritic ulcer, ring abscess, white hypopyon. The answer is very straightforward. It has to be dendritic ulcer. Dendritic ulcer is synonymous with your viral keratitis. Herpetic simplex virus, viral keratitis is synonymous with your dendritic ulcer. There is no other choice that can match to this if dendritic ulcer is given. There is no other choice that can be more appropriate or accurate than a dendritic ulcer choice. The satellite lesions are seen, we'll just discuss the other options. Satellite lesions are seen in your fungal corneal ulcer. Ring abscess, they just mean to say it's an abscess in the brain, but it is not. It is an immune ring that is seen in your fungal corneal ulcer. White hypopyon, hypopyon has to be white or dirty yellow in color, mostly. Nothing is specific. This is another question from AIMS 2019. Back then, the AIMS had separate exam. They have two things. Here they have given assertion and reason. So the assertion says topical steroids are contraindicated in viral corneal ulcer. We all know topical steroids are contraindicated in any corneal ulcer, but in viral corneal ulcer, only one where we use topical steroids. Keep this in mind. The reason they say topical steroids can cause increase in IOP. Exemption hai, but we will keep it aside, okay? Now, what I feel is the topical steroids are contraindicated in viral corneal ulcer is true. Topical steroids can cause increase in IOP is also true. But this reason is not the explanation for the assertion. If they hadn't mentioned reason and they had said just a second sentence, whether true or false, you would say both are true. Both are true. But the reason is not the explanation of assertion. This is the option that you have to mark. Right? We are clear about it. Topical steroids, there are side effects of topical steroids. One of it is known to cause glaucoma, that is your increase in intraocular pressure. Correct. But that is not the reason why we are not giving topical steroids in your viral corneal ulcer. Because if we give, the virus is going to dominate. The immune reaction that the eye is going to give is going to be suppressed by steroids. We do not want that. We want the eye to fight against the virus as well, along with your acyclovir. Correct. We have to give them acyclovir. Agree. Steroids are contraindicated. Agree. But that is not the reason why we are stopping steroids, right? IOP हो रहा है. There is an increase in IOP. But that is not the reason why we are stopping the steroids in your corneal ulcers. This is very simple. So we conclude here our topic. We'll see you in the next topic. Thank you.